pediatrician and secretary of the club, to introduce the moderator, chairperson of the next session, which is pediatric surgery. We have an eminent speaker from India, Dr. Ravi Ganoja. Dr. Kalpana, of course, Dr. Diari will introduce. Over to Dr. Kalpana to introduce Dr. Diari, please. Dr. Diari, Dr. Kalpana, Dr. Ravi, he doesn't need introduction. He has been our speaker in the past. Dr. Diari, over to you, please. Both of you don't need introduction. Your face is enough. Your picture is enough for our audience.
Hi, good afternoon, everybody. Good afternoon, everybody. Hi, Dr. Rafi.
Hi, I'm good. Thank you.
Yeah, Dr. Rafi is a well-known pediatric surgeon and pediatric urology. And he is from India. Now, today he is our guest speaker in our seminar for pediatric urology. Dr. Rafi, please go ahead. Floor is yours. Unfortunately, Dr. Mustafa will not be able to join. So I will conduct the questions with you.
Thank you so much. Thank you, Dr. Diari. And thank you for having me on this platform today in front of all the eminent speakers and the other panelists which are there. I think since morning we have had a tremendous session. So despite me being a surgeon, I still enjoyed all the talks which were there. You know, the last one regarding the vaccine and the talk by Dr. Jayashree. So I think the conference is going on really well, and I'm sure it will be even better tomorrow when you have the physical conference. So today I've been given this responsibility to choose a topic regarding pediatric surgery. And so we have chosen the topic of renal duplication. I'll share my screen. Yeah, so do you see my screen now?
Yes, yes.
So we will be talking about renal duplication. So although renal duplication is a very complex subject, and our audience, which is predominantly the pediatrician and the other specialties of pediatric medicine, are there in front of us today. What my objective will be today will be to accustom them and to familiarize them with the simple presentations of these complex renal duplications, which they may often encounter during their OPD practice. And with whatever the simple presentations these patients have, they may be able to, do an initial identification of the anomaly and then direct them to the appropriate expert for the treatment of the condition. So that's a difficult task, but I'll try my best. My basic approach would be to do a case-based scenario explanation for all the anomalies that we see. So regarding a brief introduction about renal duplication, it is the most common type of congenital renal anomaly. And they represent a spectrum of disorder. It is not like just one anomaly which you will see in your practice. So it can range in multiple levels of severity, ranging from a simple bifid renal pelvis, which can be asymptomatic, to a range at the other extreme where there is a complete duplication of the kidney and there are two moieties with two ureters, with two separate opening of the ureter which are going down into the bladder, sometimes into the bladder, sometimes outside the bladder in the perineum. So these are, one has to understand that your patient which is there in front of you with the anomaly of renal duplication, it can have a complete spectrum which is very, very wide. So it is more common in 2 to 5 times more common in girls that you see. The spectrum of clinical presentation varies with the spectrum of the anomaly which the child is having. So as this chart, you can see that it can be a simple finding of antenatal dilatation when the baby is with the mother. And later you can see it as a bifid pelvis. Most of these patients who are having mild dilatation, only bifid pelvis with no dilatation of the ureter, they can be asymptomatic. So they can be asymptomatic. Whereas as you ascend up the complexity of the renal duplication, there can be many problems associated with it. So there can be a reflux which can result into recurrent UTI. There can be obstruction in the ureter which is present there in the duplicated system, resulting in the presence of recurrent UTI. There can be pain, and even pyonephrosis in these patients is very common when they have the obstructed ureter. The ureter, as I said, can open into the bladder. Either it can open into the bladder neck in the normal area or into the urethra. And in females, it can open into the vestibule, leading to a varied presentation, which can, in males, it can result in a recurrent epididymoarchitis. We will show this as a part of our case presentation later in the slides today. Similarly, it can present with an ectopic ureter in female children, which can have a dribbling incontinence. And then there can be other problems like uretrocele, where there is a bulbous dilatation of the terminal ureter, which is present inside the bladder, and this can lead to pain and UTI in these children. So today, within the scope of our presentation, in the next 20-25 minutes, we will see some cases and see what was specifically done with these patients and how a physician can identify the condition and direct them to the expert. So let us proceed with our case. So the entire gamut of conditions which are present in renal duplications, you can see that you can have a patient with a simple renal duplication. So this is a Venn diagram, which is including the associated abnormalities. So there can be a uretrocele, there can be an ectopic ureter. So you can see that you can have a patient which can have a renal duplication along with a uretrocele, or you can have a renal duplication patient along with a ectopic ureter opening. And then there can be additional problems of having reflux in these ureters. And then there can be additional problems of having the renal dysplasia. So we will see how these patients present and various combinations of duplication with uretrocele, duplication with ectopic ureter, duplication, all three. So the centermost this Venn diagram, which can have all the components of renal duplication, such as the uretrocele, ectopic ureter, along with the reflux and component of renal dysplasia. So this is the simplest of all the patient, where you have a 10-year-old boy. He was instantly diagnosed because of some other unrelated condition, and then he was diagnosed to have 2 moieties. So you can see that there is one pelvic ileal system over here. There is another over here. Similarly, there are side also. There are 2 complete way up to the bladder. But one thing to notice is that the child is asymptomatic from this point of view, as well as there is no dilatation in the system. So both the duplicated moieties are compact, there is no dilatation, and the child is otherwise asymptomatic. So asymptomatic duplication can be present in 10% of the population. If you scan, even me or you can, we scan ourselves for ultrasound, we can have a duplicated system which we have not known for our life. So asymptomatic duplications, we don't need to do anything. These patients, even if they are free of symptoms, they don't need to be followed. So if you come across such patient in your OPD where he has been incidentally diagnosed on an ultrasound with renal duplication, the question you should be asking is that whether he has got any symptoms related to the duplication, and whether the duplicated moieties which have been shown in the ultrasound, do they have any sort of dilatation? If they don't have any dilatation, you really don't need to worry about it. You can assure the parents that it is an asymptomatic and an incidental finding, and the parents can be at peace that no surgical intervention or no procedure is needed for these kind of conditions. Now we'll start increasing the complexity of the duplications that we come across. The simplest one are the uretroceles. So uretroceles are essentially the terminal dilatation of the ureter where they are inserting into the bladder. So this diagram represents the normal trigone. So this is the normal trigone which is formed by the absorption of the terminal ureter into the central portion of the bladder. This has got a complex musculature, and the ureter is absorbed into the posterior bladder wall during the course of the embryonic development. I will not be going into detail into the embryology of this condition, but what it does is that during a normal development, the ureter gets absorbed in this portion of the bladder wall, makes a tunnel for itself, and then opens into the bladder. Thus, it prevents any kind of reflux through a valve-like mechanism, which avoids any kind of urine going back up into the ureter. But in case of uretrocele, there is a membrane formation. There is delayed absorption of the terminal ureter into the trigonal area, and there is a non-dissolution of a membrane which is called as the Chawla membrane, and it results in the terminal cystic dilatation of the ureter. This can occur with duplication as well as without a duplication also it can happen. So there is a membrane which fails to dissolve in this condition, which results into the formation of a terminal dilatation of the ureter. So again, now we'll come to the simplest of the variety of the ureterocele, which you can see in your outpatient department. So we have a 11-month-old child who is a male child, and he was antenatally diagnosed to have left hydronephrosis. So he was being sequentially followed for hydronephrosis. MCUG was done, which showed no reflux. So this is the MCUG. There is no reflux. The bladder wall is normal. The posterior urethra is normal. And you really don't see any abnormality over here. However, the ultrasound is showing a terminal dilatation of the ureter. So this is the posterior wall of the bladder, along which the ureterocele is visible, and there is mild dilatation. Now, this is a small child, 11-month-old child. He's otherwise clinically asymptomatic. We got to know about ureterocele only because he was under follow-up for the antenatally diagnosed left hydronephrosis. Now, this child, there are two schools of thought. Some of the surgeons would actually go in and do a cystoscopy and, open this ureterocele up. But it is otherwise a simple non-refluxing, non-obstructive ureterocele. So some group of surgeons may choose to follow this child over a period of time. And if the hydronephrosis is not increasing with time, and if the child is asymptomatic, he can be conservatively followed. So this is the pictographic representation of this particular example, where you can see that the ureterocele, there is a duplex system, and the upper part of the ureter is opening as a ureterocele. It's a non-refluxing, non-obstructive ureter. So if you see this kind of ureterocele in smaller child, you can conservatively follow it for some duration. And depending upon the progress of the symptoms and appearance of the new symptoms or the progress of the hydronephrosis, you may choose to intervene or you may choose to follow him conservatively. One of the choices where the surgeon will choose to intervene and do a cystoscopy and cutting of this membrane will be if there is increasing dilatation, increasing urinary tract infection, and worsening of the renal function on the MAC scan. That is the time when you will choose to intervene in this patient. So he needs to be serially followed. Second case scenario for a ureterocele, more severe variant. Now this time it is a 4-year-old boy. He's got a right side duplex and he had recurrent UTI with ultrasound showing that there was a right duplex. So this is actually an IVP. Nowadays IVP is out of the fashion, but in case of duplex anomaly, IVP is of tremendous value because they accurately delineate the calyceal anatomy of the patient. So here you can see that there is a filling defect representing a ureterocele inside the bladder. And this patient is similar to the previous patient, but he's got recurrent UTI this time. He's got hydronephrosis. And once you do so this child cannot be followed conservatively. There has to be some surgical intervention. And the treatment which is required for this patient is cystoscopy and de-roofing of the ureterocele. So what we have done is shown here is that this is the cystoscopic view. This is actually the place where the normal ureteric orifice should have. But instead, what do you see? That you see a portion, which is the terminal dilated portion of the ureter representing the ureterocele. So this is the ureterocele, which we have seen in the previous diagram, in the pictographic diagram. So this ureterocele, when you see live intraoperatively, it constantly distends and deflates with the bladder pressure increasing or decreasing with the water flow. So this is very diagnostic of presence of a ureterocele, and all we have to do is to cut the wall of the ureterocele so that it opens up and it allows a free passage of the urine. Now, in most of the conditions, the patient will need a follow-up MCUG after the ureterocele has been incised. So this patient was lucky not to have a reflux. So this is a post-incision MCUG, which is here. He did not have reflux, and then we followed him conservatively. In some cases, there can be reflux. If the reflux is severe enough, and there is again presence of recurrent UTI, this patient will have to undergo a reimplantation procedure. Now, there is another patient where there is a bilateral duplex and a bilateral ureterocele. This is actually not a duplex. This is single system. Both sides you can see single system, but there is dilated ureter. And in the end, you can see that there are two bulbous terminal dilatation of the ureter, and it is a bigger child. There is no reflux, but these two are very big ureteroceles. The patient will be symptomatic. He will gradually lose kidney function and will have increasing hydronephrosis. So this is a boy who will present with recurrent UTI, pain, cystitis, and then you will have to investigate. So if this is showing bilateral ureterocele, very rare example actually. And this is the So this is the cystoscopic view of this same patient who had the bilateral ureterocele. We are going into the bladder now. So you can see that these are two large bulbous dilatation which are present. So that's a ureterocele. This is the ureterocele on the other side. So these are flabby membranes, and they distend as the urine flows from ureter or into the bladder. But usually during cystoscopy, because there is a positive pressure because of the water flow from below through the cystoscope, they tend to collapse. You can see that this ureterocele is now collapsing. So this is a classic view of a bilateral ureterocele, which is seen in these patients. So what did we do? Since this had a very big bilateral ureterocele and it had a fair chance of having severe reflux after you cut the ureterocele, and so if you cut this ureterocele like this, they will have a very severe reflux, and then they will have to undergo a second procedure where we will have to do the reimplantation. So in this patient, we directly decided to do the reimplantation immediately once we finished the cystoscopy procedure. So we excised these ureteroceles and did a reimplantation procedure, and the patient did well in the post-op period. Now we will come, so this was our spectrum of presentation with the ureterocele. So you saw 4 patients in a sequence where the youngest one had the mildest of the symptom. He was followed conservatively, very small ureterocele, and then as the severity increased, we came across this 4th patient where he had a very big bilateral ureterocele. He was incised and he had to undergo a ureteric reimplantation. We will now come to the other part of the ureteral duplication, which is the renal. So now, renal duplication, they generate certain rules. So the diagrams are showing those rules. What these rules say, that the ureter from the upper moiety always opens medially and can have an obstructive element because of the ureterocele formation. Whereas the ureter from the lower moiety usually inserts lateral in the bladder wall, and then it can have the element of reflux with it. So this is a general rule which is present in duplicated system. It is called as the Mayer-Wieget law of kidney duplication. Okay, there's one more rare variant of ureterocele, which is the prolapsing ureterocele. And there can be an ectopic variant, and then there are some ureteroceles which can descend down, and they can go so much down that they can present as a vaginal protruding mass either at birth or later in life. So this is actually a ureterocele which is traveling all the way from the bladder trigone area right up to the vaginal introitus. So these are few conditions which you must be aware of, and if you come across these conditions, if you direct them to the appropriate person, early treatment can be initiated in these conditions. So coming back to the main component, which is the renal duplication, where we will focus on the duplicated part itself. So again, it is a spectrum. It is not one single condition. So there can be a simple bifid pelvis, which we call as the incomplete duplication. And then there can be a complete duplication with dilatation but intact function. So this was the very first patient with the compact kidneys and no dilatation. So most of these patients are asymptomatic. And then complete duplication, the other end of the spectrum is the ones which will need active intervention and investigation, where there is a duplication and one of the 2 moieties of the duplication will have problems. And then there can be either a reflux or some other problems with these patients. We will discuss these patients more with the help of the examples. So now this is a 5-year-old boy diagnosed after recurrent UTI. And then there is a left duplex. So it's a left complete duplex. On the right side, there was right bifid. So we can ignore this side. We'll just focus on the left complete duplex. And we did a DMSA scan. So there is a upper pole non-functioning kidney. So the upper moiety of this kidney, which is present as a duplicated system, is completely having no function at all. And then there is a topic opening of the left ureter at the bladder neck, which is seen on the cystoscopy. So there has to be a particular sequence of investigation which has to be followed in these kind of complicated patients. You obviously, the initial diagnosis is always triggered by an ultrasound, and then the ultrasound should be followed by an MCU. And then the DMSA, which will ascertain the function of the 2 moieties on the upper and the lower moieties. And then later on, the patient can be taken to the OT with a plan, and then we do a cystoscopy and examination under anesthesia to define the anomaly further. If you reverse these 2 investigations, if the DMSA is done first and the MCUG is done later, if MCU is showing reflux, then the function which is established on DMSA scan can be falsely high. Because of the reflux, more of the radiotracer material will be seen in the cortex, and then it will have falsely elevated. So it is better if you have on MCU, if there is ureteric dilatation, if there is reflux, it is better to do the DMSA with the catheter in bladder so that your studies are accurate. So that is why I emphasized on the sequence of the investigation, which is to be followed in these patients. So this is the schematic representation of this particular patient, where you can see that this is the upper moiety, which is sort of represented as being dysplastic. The ureter is dilated, and then there is a terminal dilation, also a uretrocele, which is present in this child. So now, no matter what you do, even if you incise this uretrocele, the function may not improve. He will have reflux, and then this non-functional moiety can always have problems and keep causing UTI. So this is the investigation. We actually did a MRI in this patient. You can see that this is the dilated portion of the upper moiety. The lower part is compact. This is actually the dilated ureter seen on the cut section. Again, this is the dilated ureter, which is seen like this. This is dilated ureter, and this is the bladder. So this is the subtraction image where you can see that this is the dilated ureter, which is going all the way down. So it is what we did a left upper pole nephrectomy. So this is the pelvis view. This procedure was done laparoscopically. You can see that this is the dilated ureter, which is going down into the bladder. It is much better appreciated on the video actually. So this is the view of the kidney. This is the normal kidney, and this part of the kidney is the dysplastic moiety, which needs to be removed, and it is connected with this dilated ureter. This is the post-op specimen where we have taken out all the dysplastic moiety over here. You can see how the dilated ureter is there, and this was giving tremendous problem to the child. Once this dysplastic moiety is taken off, the child goes home all right. Now there are conditions where you can have where the two moieties are intact, so there is no loss of function, but the ureter which are opening into the bladder is having reflux. So this is just a video where we are showing one representative case. So this is the ureter grossly dilated, and there was actually a uretrocele. So you can see that this is the site of the previously incised uretrocele. It has opened up, and this was causing that massive reflux, which was seen in the previous slide, being the dilated appearance. So this is the ureter for which the moiety is normal. This is the lower moiety ureter. So what we did was that since both the moieties are intact with their function, we cannot excise those moieties. So we have to treat the reflux. So this is a procedure of vasicoscopic reimplantation, where we have done a common sheath reimplant in this patient, and hence eliminated the reflux. So this is a long video. I will not show the entire video because of the time, but we have mobilized the ureter. You can see that the two feeding tubes are going into the two ureter, and the two ureters are mobilized, and a Cohen's reimplantation was done in this patient. So as you can see, we are mobilizing the ureter. It is a little tough job in case of previously incised uretrocele and then duplex ureters are present. It is very important to preserve the wall of the two ureters, and you have to mobilize in a way that you don't damage the bladder as well as you don't damage the ureter as well. So you can see that this has got two ureters. It has been mobilized now. This is one non-dilated ureter, and one of the ureter is more dilated than the other. So dilated one is the lower moiety ureter. So we are mobilizing it. The ureters are coming out nicely, and then a tunnel is made, and they are pulled into this tunnel. So this is a classic vasicoscopic reimplantation. We do a lot of these procedures, and with very successful results. So you can see that this is one ureter, and this is the other ureter, which will get reimplanted into this mucosal tunnel and will eliminate the reflux. So in this way, both the upper moiety and lower moiety, which are intact in function, are preserved, and the problem of reflux is tackled by the reimplantation. So ectopic ureters. Now, some of these ureters may not end up in the trigonal area. They can go from anywhere between the trigone right up to the vestibule in females. So it is more common in females, and in females, the 80% will involve the duplex system, and majority of these cases are below the sphincter, which will cause incontinence. So the vagina and the urethra are the most common place where the ectopic ureter is going to open. In contrast to that, in males, mostly they are single system and they drain into the posterior urethra or suprasphincteric, and they often communicate with the ejaculatory duct, resulting in epididymoorchitis in these patients. So if you come across a patient with a recurrent epididymoorchitis or abscess in the area of the scrotum where the testis is involved, always take a suspicion that has he got a duplex system. An ultrasound scan should be done in this child to rule out any kind of ectopic ureter. So as I said, in males, it is suprasphincteric in location. Incontinence is usually not present because it is above the sphincter. And you can see that this ureter is very close to the ejaculatory duct, which is present here, which will cause the reflux of urine going into this ejaculatory duct, and ultimately via the vas, it will go down into the testis and cause epididymoorchitis and inflammation and infection over here. So again, to explain this with a case scenario, this is a 4-year-old boy where you can see that this is the kidney where hydroureteronephrosis is present. And you can see that this ureter is going all the way up to so this is the bladder. It is going all the way up to the bladder neck. And it is opening somewhere here. And it will cause recurrent epididymoorchitis in this patient. So what we did in this patient, he just simply required disconnection of this ureter, which was going down. And it was reimplanted as a Politano-Ledbetter reimplantation, and all his infection problems were cured. So this is, there are conditions where you can have duplex with reflux in both moieties, but one of the moiety would be non-functioning. So you will have to do a reimplantation in one of them and totally excise the dysplastic moiety and in the other kidney in order to eliminate all the symptoms. Now, ectopic ureter is a very common problem, especially in females. As I said, it is intrasphincteric in location, and incontinence is the most prominent symptom. So again, a case scenario, there is an adolescent female who had a history of recurrent UTI, and the characteristic of incontinence is very, very important in this kind of condition, and a very good history taking regarding the voiding problem, and the voiding pattern is very, very important. Now, this child was passing good stream while voiding, but in between she used to dribble, and there was a bedwetting problem. Parents failed to recognize that there is some anatomical problem. And for bedwetting, she underwent a very long pharmacotherapy and then even a psych evaluation for the child. And then, it caused so much of morbidity in the patient just because she went undiagnosed. So when she was diagnosed, you can see that this is the ureter, which is opening right to the level of the vestibule, and with a dilatation. So this is almost a non-functioning kidney, but some function is preserved because she has this moiety is making urine out of it, and she's dribbling. So this photo is not for this particular patient, but it is representative. You can see that this is the urethric orifice where the Foley is in place, and then there is a very small opening where this ureteric stent has been placed. It is the opening of the ureter. So since it is out of the sphincter mechanism, it will always cause the dribbling incontinence in this patient. So the classic history, which a pediatrician, if he is attending such patient in his OPD, is that there will be good stream urine, and in between 2 episodes of voiding, there will be dribbling and wetting of the undergarments. So it is in contrast to other form of ureterosis where you will have a constant dribbling and the child will always have an empty bladder, and there will be no stream of urine which will be present. So in this way, you can actually distinguish between a presence of an ectopic ureter or presence of some other organic problem in this child where there are problems with the bladder, neurogenic bladder, or any other detrusor problems in the bladder. So in this condition, what is the treatment? The treatment is the nephrectomy for dysfunctional moiety is usually curative, or if the moiety is functional, you can disconnect the ureter from here and reimplant it. So this is my last slide, Dr. Saurabh. I will be finishing in a minute. And now this slide presents the general spectrum. So I had given examples with all the kinds of patients that we can come across in duplication. So this was the mildest one where it is asymptomatic, where we just leave it alone. There is a ureterocele where a simple incision completes the treatment when the child does not have any reflux. If he develops reflux, so this is a reflux which is developing. If he develops reflux, then we will have to reimplant. If it is obstructive, you will have to drain it, which can also be by reimplantation. If there is an ectopic ureter which is opening down, you will have to reimplant versus excision of the dysplastic moiety if it is non-functioning. And then you may have to do a nephroureterectomy of the dysplastic moiety. So you remove the dysplastic moiety along with this ureter to get rid of the infection problem. So if you are generally aware of all the spectrum of duplex conditions, you will very well be able to recognize this condition in your outpatient department and direct these patients accordingly to the experts. So with that, I end my talk, and thanks to the DPC team, which has done an excellent job in organizing this vibrant conference. And thank you so much. I'll be open to questions now.
Thank you very much, Dr. Ravi. Thank you. Excellent presentation. Actually, I don't know how you managed to summarize all duplication in this presentation in half an hour. Really, it needs a chapter. In urology, it is a chapter.
Yeah.
Very, very well done and simply. Now, to be honest with you, I was very happy with your and enjoying your presentation. I did not look at the question and answers.
Yeah, actually, the question that I see here, Doctor, that is regarding prophylaxis of antibiotics, opinion regarding that. So,
yes,
Dr. Ravi, would you like to take
very pertinent question. So these patients who are clinically asymptomatic, as I said, the ones on the milder extreme of the spectrum, they will not require any kind of prophylaxis. The indication of prophylaxis would be that if there is a reflux which is being followed conservatively, or if there is a dysplastic moiety, there has been a previous presentation with recurrent UTI, which is a culture positive UTI. These patients, until a definitive treatment is instituted, should always undergo, should always have a prophylactic antibiotic. Otherwise, they will keep coming to the hospital with the recurrent infection, and there will be a morbidity in these patients.
Okay, for how long you are giving prophylaxis, until which age?
So that's what I said. The prophylaxis has to be continued until a definitive treatment is established. So either a ureterocele excision has been done and there is no reflux. Once the no reflux has been demonstrated, you can stop the antibiotic prophylaxis. But if there is still prophylaxis, even a low-grade reflux is present, you will continue the antibiotic, follow him sequentially, and at least minimum 2 years are required for these patients. And once they gradually outgrow with the growth of the bladder and the physical growth of the child, then at that time you can decide on when to stop it after 2 years, depending upon the ultrasound monitoring of these children.
Would you like to go for cyclic prophylaxis or continuous prophylaxis?
Cyclic prophylaxis always, because if you continue with have breakthrough infections and have antimicrobial resistance versus cephalexin, plus minus nitrofurantoin. In fact, 3 antibiotics cyclically are given.
Right. About this ureterocele
we know that patient.
Yes, Doctor.
Dr. Rafi, I saw the case with a male to have a bilateral ureterocele, although we know that the females usually they have more ureterocele than male. Now, yes. You know that the bladder dysfunction in these cases is very common, especially yes. These big ureteroceles, which taking all the posterior wall, all the muscular wall of the bladder.
Yes.
And when you are doing surgery, most probably we have much more problem. How you are usually following these cases?
So the first caution that we exercised in this particular patient was to have a really, really long tunnel so that the reflux can be avoided at all cost. That is the prime thing. And otherwise, if the bladder is otherwise structurally normal, they do well in the follow-up period. But if they have a, sort of a bladder dysfunction, pharmacotherapy by oxybutynin or tolterodine is given to them. And they usually, with physical growth, they outgrow these problems. And sometimes they require a longer antibiotic prophylaxis and monitoring of the post-void residual urine in these patients, to monitor them in the OPD. But yes, these large ureteroceles, I agree that they have some element of bladder dysfunction in the follow-up. And they will need a longer follow-up of 4 to 5 years after the initial surgery is done and reflux is eliminated.
Yes, Dr.
No, I was just asking regarding that uretrocele, when you're deroofing it and definitely post incision, you want to rule out there is a reflux. Do you do it on table? Do you do it later?
No, it is done almost 6 to 8 weeks after the uretrocele incision is done. Some people will do it after 3 months. So it is never done immediately, because if you do it immediately, it will 100% of them will show reflux, because that flap is big, nice and open. There is a wide ureteric orifice. So all these things contract in due course of time. And the uretrocele, which has been incised, the flap over there, sometimes it acts as a flap valve. And if the patient is lucky, that flap is going to prevent the reflux. So the optimal timing of MCUG after the uretrocele incision is anytime after 8 weeks. 8 weeks to 3 months is the window period then that we order it.
And definitely till that time, they would be on prophylaxis.
Prophylaxis, yes. Till the status is known that the reflux is not there, the prophylaxis has to always be there.
And what would be the... Yeah, doctor, go ahead.
Yeah, Dr. Rafi, as you know now, people, they are going away from the surgery and more or less going through toward the laparoscopy. So what's your experience with bilateral reflux or duplex kidney or duplex ureter refluxing? Do you still do it bilaterally, do laparoscopy, or only vasectomy? I mean, reimplantation.
Yes, very good question. So now, once it is decided that this patient will require surgical procedure, either in the form of a sort of a heminephrectomy or a reimplantation. So if it is a reimplantation, if it is a bilateral reimplantation, I will always prefer to do a bilateral vasectomic reimplantation, so we do not disturb the posterior bladder wall. And we have done quite a few vasectomic reimplantation for these kind of patients. Even we have done a robotic vasectomic reimplantation. The vasectomic robotic is actually a published series from our side. We have even done laparoscopic nephrectomy and robotic nephrectomy, even retroperitoneoscopic partial heminephrectomy along with the excision of the rest of the ureter. In fact, laparoscopy or minimally invasive approach gives you the added advantage that sometimes if you have to do a nephrectomy as well as a reimplantation at the same time, you will not require 2 incisions. You can just do it laparoscopically by pointing it up and down. And we have done that in few patients where in the same sitting, the nephrectomy was done, upper moiety nephrectomy was done, and the lower moiety ureter was reimplanted by means of vasectomic reimplantation. It was presented in few conferences as well. So all these procedures are now being done robotically also very successfully. And back in PGI Chandigarh, we have been doing it very regularly in our patients, especially the robotic approach now is very, very common.
Maybe one interesting topic, hydronephrosis obstruction in a duplex kidney. Do you have any experience with that?
Yes. So those are other forms of anomalies which are not within the scope of this current topic. But hydronephrosis in duplex kidney, hydronephrosis in horseshoe kidney, these are special circumstances which we have tackled, both laparoscopically as well as robotic, and it gives you a very good view of the anatomy during the surgery, which may not be so well appreciated, during the open procedure. So we have done that where there are vascular anomalies, where there are horseshoe anomalies, and then renal duplication anomalies in these patients. Even triplication, we have done triplication of the ureter in there's one patient which is published as a case report, and where a reimplant along with a PUJ obstruction, PUJ surgery was done.
The double obstruction. So you are doing it in the same time or separate occasions?
Yeah, in the recent of our patients, we have done it in the same time.
At the same time.
Yeah.
The case of ectopic ureter, how challenging is the surgery there, depending on where it opens up?
Yeah, so ectopic ureter, if you are preserving the kidney, all you have to do is to disconnect that ectopic ureter from its ectopic location and put it back in the bladder. So open wise, it is, I would say it's a moderate level challenge for a experienced surgeon. And all he has to do is to reimplant the ureter effectively to eliminate the reflux. Most of these surgeries, you put a stent first so that you are able to feel where the ureter is during the surgery, whether you're doing laparoscopically or by open surgery. Once you properly identify the ureter, you will be able to disconnect it and put it back in the bladder.
I feel the diagnosis is more challenging than the surgery.
Yes.
Sometimes they are opening bilaterally to the vagina, which you cannot identify the place. And most of them, they are presenting with incontinence. They are coming to you that they are only dribbling. And the situation to find the position is more difficult.
Right. And what would be your absolute indication for partial nephrectomy in duplication? Like you said, the upper moiety not functioning. Also, another thing you said was IVP is going out of fashion. So what are your, what is your, radiological investigations or modalities that you depend on? Or do you still go for IVP pre-op as most of the surgeons used to?
Yeah, so the first question about the threshold for removing the dysplastic moiety. If the function is less than 10%, and you on the ultrasound, you are able to see that it is a very small lump of tissue present over the kidney with an attached dilated ureter, then there is no question that you should preserve this part. It is better to remove. Patient is having recurrent problems and is having frequent hospital visits. So anything below 10% function, you should actually remove these kidneys, which can be assessed on the DMSA scan. There is a common misconception that there is duplex. Duplex means that you have two equal halves of the kidney. It's not like that. So one is like 90% and the other duplicated part is just 10%, which is causing 100% of the problems. So you have to get rid of that 10% kidney, which is sitting on the top as a part of the duplex. Regarding the IVP, yes, IVP is now out of fashion because of the radiation reasons. So the alternative to IVP, as I showed in one of our patients, is MR urography. And MR urography, if properly done by experts, is a good replacement for the IVU. It will give you the same kind of anatomical details, which can be seen on the IVP as well.
So Rafi, what's your opinion now? Most of the, let's say, our colleagues, pediatrician, or even the family themselves, per week they are doing twice midstream urine analysis. And so many times we have an asymptomatic bacteriuria which has been treated by antibiotic. So what's your opinion?
That's kind of an overdue of whatever the resources that are available to the patient. I would not advise for that until and unless he is suffering with some organic symptoms, like there is a febrile UTI, burning, micturition, then only you will have some positive findings. Otherwise, if the patient is clinically well, no febrile, no fever is present, he is otherwise eating well, general well-being is fine. Even if you have some bacteriuria in the urine, especially in the females, is not of any significance. And the more you do it, the more bacteriuria you will find, and the more the family is going to be concerned. The more antibiotic you are going to prescribe. It all leads to a cycle of overdoing all the things. Yeah.
Okay. Dr. Saurabh is here to remind us of the time.
Thank you very much. Your next session is going. Thank you very much, Dr. Ravi. Really, as Dr. Diari said, it was excellent as usual. Next year, we'll invite you to come personally. We promise all overseas speakers are invited from now to come to our next year conference physically. So we'll enjoy your presentation here in Dubai. Thank you very much. Thank you, Dr. Diari, for moderating. Thank you, Dr. Kalpana.
Thank you, Dr. Kalpana.
Now, next session, we move to pediatric care. Pulmonology, Dr. Omi and Dr. Vishwanath, from 2 o'clock, they are sitting there. Next session, we have an